Welcome to the third in this video series, during which Dr. Feil and I will discuss barriers to herpes zoster vaccination. In this video, we will introduce a number of barriers. In the fourth and final video, we will describe ways to overcome them. James is a 61-year-old male with a 10-year history of type 2 diabetes, and he's at the office for a routine appointment. On review of his electronic health record, his PCP notices that James has not yet received his herpes zoster vaccine and asks whether he would like to receive it today. James declines, stating that he never had chickenpox, so why would he need the vaccine? James also indicates that he is distrustful of vaccines in general, stating that he once caught the flu from the flu shot. Sounds typical to me. So let's talk about the low rates of vaccination among adults. It has been the goal of Healthy People 2020 to get folks vaccinated at a high rate. For zoster, they set a relatively low goal because this is a relatively new vaccine on the market. Nevertheless, despite our goals, the overall vaccination rate for all of the adult vaccinations is relatively low. Zoster is at a pathetically low rate of 28%. So you can see when zoster was introduced in 2007, we've had about a 4% increase in vaccination coverage every year. At this rate, it'll take us decades to get to vaccination coverage for the entire population.
Well, now let's look at barriers to herpes zoster vaccine, particularly those amongst physicians, and then as well as patients. But if we look at physicians specifically, in this study of about 600 primary care physicians who were asked how strongly they recommend the vaccines that are listed here, which includes herpes zoster, Tdap, pneumonia vaccine or pneumococcal vaccine, and influenza vaccine, you can see specifically for the herpes zoster vaccine, the percentage of physicians who strongly recommend this is significantly lower than the other vaccines. And as we'll discuss as we go through this video, that's a very important issue. That is how strongly we actually, as healthcare providers to our patients, recommend this vaccine. And this becomes very important. Now, if we look at the specific reasons why physicians may not strongly recommend the vaccines, particularly herpes zoster, to their patients, you can see that the most frequently mentioned barriers or problems or issues are related to finances. It's either the cost to procuring the vaccines in their own offices or the concerns for costs of the patients. In addition, there's the logistical issues of storing the drug, or at least the vaccine, requiring an adequate freezer and actually monitoring that freezer to make sure it's appropriate. And then the last point there is something that applies to the administration to vaccines for all adults, and that is oftentimes when adults go to the physician, there's other more acute problems that the physician is more concerned about than administering preventative vaccines.
So one of our challenges is how to get the vaccine paid for. Zoster vaccine is covered under Part D, but many physicians can't directly bill. Many patients must purchase and then seek reimbursement. And if they have other kinds of insurance, their co-pays and deductibles vary. Some may be cost prohibitive, and the vaccine can be expensive if you have to pay for it out of pocket. In contrast, influenza, pneumonia, hepatitis B vaccines are all covered under Medicare Part B with no co-insurance or deductible.
Now, we know that there are many questions and a lot of confusion among certain physicians about barriers and how we use how we administer our herpes zoster vaccine. And I'm just listing some of the common questions here. We'll be discussing the answers in greater detail in subsequent video, but the questions here are, why is the vaccine FDA approved for patients ages above 50, but yet the ACIP, the Advisory Committee on Immunization Practices, recommends that for patients over the age of 60? Or how long does immunity last? Or is there even a need for a booster? Or is there even a recommendation for a second dose? Can a patient be too old to receive the vaccine? And then there are questions about immunocompromised patients. Which immunocompromised patients can get the vaccine or should get the vaccine, actually, and which patients is the vaccine contraindicated because of their immunosuppressive status.
So there's, as we heard about, one of the most important factors is a strong physician recommendation. And on this slide, you can see that physicians endorse that they recommend vaccines to their patients 87% of the time in a reliable way. But patients tell us something different. Less than half of the time do they think their physician either regularly or occasionally discusses vaccines with them. Even a significant proportion don't recall ever discussing vaccines with their primary care provider. So I think no matter which side of the data you believe, I think we as physicians have a way to go to doing this in a consistent way that provides a strong recommendation.
I think part of the problem relies in the message. We should not give an ambiguous message. I mean, that was the message that the primary care physician gave to our patient that we presented earlier when he asked, do you wish to get the vaccine? I mean, this is something that we should tell the patient, or at least advise the patient, this is something that we strongly recommend, that this is time for this patient to get the vaccine. So using the terminology as shown in this slide, do you want to get the vaccine or think about getting the vaccine? These are not strongly worded recommendations, and they're too ambiguous. And so in the future, what we really want to stress is that we should all be champions to promote strong recommendations for the vaccines.
It shouldn't be framed like a choice. Like when we offer vaccines to children, we're really not offering it. They're up for their schedule. Right. This is what's due.
Right, right. And that's absolutely the case we should do for our patients as well, not only for this vaccine, but the other vaccines that you mentioned in that prior slide.
In the same way, the physician barriers of how we present this, there are patient-level barriers. So on the patient side, patients may just be unaware of which adult vaccines they should receive and when. We have lots of different vaccine schedules, so to expect them to know that they should be getting their shingles vaccine, I think, is beyond what the typical patient can presently do. There may be an unawareness of why they should appreciate a vaccine and what they're preventing, the seriousness of herpes zoster. They may know about vaccines when people got a vaccine and they got the disease anyhow. They may not understand that the vaccine can still attenuate disease even if they don't get complete protection. Certainly I've heard people think that they get the disease from the vaccine. I've heard that with the flu shot. And if they have that concern about shingles vaccine, I think it's just room for education. Fear of needles isn't an uncommon problem. Insurance issues are things that come up. And then there's the anti-vaccine movement, which perhaps isn't as large for shingles vaccine as it is for others, but clearly is one of the things we should be prepared for. So common questions that we get is, I already had shingles, doesn't that mean I'm immune? Or, I never had chickenpox, why would I need the shingles vaccine? My family member is immunocompromised, can she catch shingles from me if I get the vaccine? So, shortcomings of our vaccine education is when we talked with our patients, do we understand where they're coming from, why they are declining or reluctant to get the vaccine? And when we think of this, we can think of 6 basic styles that patients run through their mind. One of these is typically one that they lean toward to choosing to not get a vaccine. For example, denialist is they just don't believe any data, and so why should they start believing something now? The problem with innumeracy. You tell them about how much their risk reduces, but they don't actually understand percentages or risk in numeric terms. Or fear-based. They're afraid of something about the vaccine. The heuristic one, they hear of a thing that happened with the vaccine once, and they now take a shortcut in their mind and apply it to everything about vaccines. Bandwagoning. None of their friends have gotten the vaccine, so why would they? And then finally, the analytic approach. This is sort of a left brain. They want all the details and they want all the facts. Until they get all the facts, they're not going to make any decisions. And so when you think about these styles of refusing vaccine, you can also use these as strategies to figure out how to get to them and change their mind. And those will be topics of our next video. So this brings us to the close of the video. To summarize, rates of herpes zoster vaccination rates in adults over the age of 60 have improved but remain suboptimal. We have lots of room to go. There are significant physician-level barriers that include miscommunication and cost reimbursement challenges, and how we do our messaging. There are patient-level barriers, which include misconceptions about herpes zoster and the herpes zoster vaccine and varying insurance coverage. And finally, practical strategies are needed to improve vaccination for zoster in this vulnerable population. I want to thank you for participating in this video and invite you to view the final video in the series, during which we will address the barriers identified here. In addition, I'd like to thank Dr. Feil for joining us today and to point out the helpful resources for clinicians and patients pertaining to herpes zoster vaccine recommendations, as well as recommendations for other adult vaccines. The adult vaccine schedules from the Advisory Committee on Immunization Practices and the American Academy of Family Physicians website has more information, as does the one for the Gerontologic Society of America for the National Adult Vaccination Program. Thank you again for joining us.